Good evening, everybody. Good evening, sir.
Good evening.
Good evening.
So I think, first of all, let me actually have let me actually say that it's wonderful today to be a part of the 96th edition of the DigiConnect webinar. I think it speaks volumes of how we have progressed over the couple of years, and all of these sessions have been immensely appreciated. So today is going to be a very interesting session. And for all of you who have always been interested in what are the new advances in the field of medicine, when I say medicine, it's precision medicine and molecular oncology. I think we are going to have a good amount of insights of what's happening, what's coming up, and who can be a better person than our own Dr. Puneet Chandna to actually share more insights on the subject. But before I actually invite him, let me first of all call upon the president of Occupational Health Association Delhi, AOH Delhi, Dr. Gajendra Kumar, to share a few words.
Good evening, friends. As Dr. Ashish already mentioned, this is our 96th webinar. And through this webinar, in this hard time, for last 2 years, we will be regularly meeting every Saturday and discussing various topic of interest. So today topic is going to be very, very interesting, and our known Dr. Puneet Chandna is a well-known molecular biologist, and is the right person for the deliberation on this subject. So with these few words, I welcome you all to this program and hand over to Dr. Ashish for further deliberations.
Thank you so much, President Sir. And I think as I just touched upon, so today we have Dr. Puneet Chandna, and Dr. Puneet Chandna is going to speak on frontiers in diagnostics and modern medicine, molecular medicine. What is the next generation diagnostic testing and therapeutics? It's a very interesting topic, and Dr. Puneet Chandna, just to give a bit of more insight about him, he has done his MD in internal medicine. He has done his PhD in biophysics. He has been a past faculty at ACTREC Mumbai. He has huge amount of experience spanning more than 2 decades in the bioanalytical sphere. He has been a sought after speaker. He has been a consultant to several international societies. He has been author of more than 32 publications on the subject, and his expertise has been sought by leading international centers like Harvard, UCLA, Ohio State University, Pennsylvania, and others. So it's a very interesting topic, precision medicine, and I'm sure that many of us have always been looking forward to this topic. I really want to actually, first of all, welcome and thanks to Dr. Puneet for consenting to be out there and speaking on the topic today. So without further ado, I'll actually invite Dr. Puneet to take over.
Thank you very much. Good evening. Thank you, Dr. Jain, and for your nice introduction for me. It's a pleasure to be here again on the 96th the session webinar we have on the series 1. And thank you very much, President Dr. Gajendra, to have me here again. It's a pleasure to always be looking up to you as a lead onto these webinars, and I'm sure it has not fallen prey to the COVID times, and now we are opening up. It'll be much more better, and I look forward to and your allowance to begin my talk, sir.
Please.
And for good reasons, I'll just put off my video and share my screen. Can you see my screen, sir?
Yes, please.
All right, great. Today's topic as on the Enoch talk, which is series 196. And allow me to bring up the disclaimer as usual. The data we have captured, and it may have some sensitive information. So its discretion is and selectivity, and I would say discretion is always required. So allow me to go forward, and I promise you a good presentation from here. The lineup or the agenda I have here is on the molecules of life. It's just one slide on the basics. It helps me build. I'm sure everyone knows about me. And then about the topic, it helps me build with a small amount of basics, because that's what is important when it comes to molecular medicine and therapeutics. I'll be linking chemistries with the next-gen biomarkers. A few slides from my erstwhile presentations at the webinar series here. We'll talk about the advances in AI as well, frontier applications. And again, when I say the advances in AI, again, is to sum up and link all of the above together, rather than independence of AI in the futuristic medicine endeavors we'll have and the road ahead. So allow me to begin with the kind of central dogma for the cell structures we have. A cell is, you can look upon as a cell as a work from home office. You have the nucleus where you work from, and maybe the workshop is the endoplasmic reticulum, the bathroom, which is the cell membranes and the walls, and so on. So it is quite representative, I believe. So imagine as a cell, what I have tried to depict here is a cell is performing a lot of functions. And the major functions are with the boss sitting in the office, which is the DNA. When we classify by specialty, the cellular and molecular biology would look at smaller molecules in the living system, if I have to say. When I say living system, it is all the species we see around us, any living organism, or even the microbes, which are further classified into bacteria and viruses as well. All have the building blocks that they have cells. Inside the cell, we have a nucleus. Inside the nucleus, we have chromosomes. And on chromosomes is wound a double helical structure called as DNA, which has got small reed segments called as the genes. So moving forward, I'm not going into detail what it consists of, but then it's very important in the integrative medicine. What I'm going to talk about and my expertise is that we look at not only treating the symptoms, we go into the source of the ailment, so to say, and also plan to do that across markers, the techniques in diagnostics are available, which are available to us, and all the way through the life cycle of the disease. That is from where it starts and how it ends. Unfortunately, there are many, terminal illnesses in cancer. So I would not use that word to the end of the life, but then it's through the life cycle of the disease. Going forward, we look at biomarkers, apart from, which is bio is just the body as we know, and the markers are something which we can analyze. So we all know about biomarkers when it comes to, the tumors or the cancers per se. We have various cancers in various organs of the body, and these correspond and help us, deliver certain biological fluids or certain biochemical parameters, which we can analyze, so as to look at the blood chemistries and confirm the diagnosis of cancer. So when I talk about the blood biomarkers, it's always read clinically together with imaging studies like the X-rays, CT scans, MRIs, the biopsies, which are a very important confirmatory step here. And then nowadays we are trying to use certain AI. I'll introduce the artificial intelligence or the data-based algorithms, or so to say, the calculators, which are now available online, some of them free of cost, to in fact give us, a score-based reading, incorporating all the diagnostic parameters we have, from low to undetermined in case, the software is not able to call it, and high in terms of, likelihood that a person may have a disease or, let's say, cancer. So when we are talking about molecules of life, we talk about genes, we talk about methylation, which is epigenomics, which is a new field that's coming up, transcriptomes, and proteomes. So when we call omes, it's like a study which is collective, like genetics is few genes or one gene, and genome is the whole genetic data we may have across that particular species. Like for the whole genome of human would have all the chromosomes read in terms of its DNA sequence. Epigenome is the epigenetic profile, which is the methylation, a part of the part which is before the genes. So if I have to talk about, is gets methylated and controls the expression of the genes. Transcriptomes is essentially the area we'll come to know is concerning RNAs and proteins. Of course, we all know is the study is called proteomics. Biomarkers, when we say, we must have heard about mutations in the last 2 years several times. This mutation, that mutation, hundreds and thousands of mutations. In fact, there are hundreds and thousands of mutations, across the human genome as well. But then the mutations are something, it's not only a base that changes or a part of the sequence or a unit of sequence that the DNA is producing changes, but it can be in combination, couple of them, repetitions, and so on, and sometimes called as nonsensical or idiotic mutations as well. But how do they exist is because of the makeup. When I say the genotype would mean inherited components we have from our parents. The behavior is what we are doing, and with our body, what kind of food we eat, you won't believe me, can change the DNA sequences as well. The chances, like during the early development of life, the chance could be that there are a million steps that happen when the cells divide, and by chance one may go haywire, and you may have a mutation. The environment is nothing but pollution and the water and the air we breathe in daily lives, so that it causes mutations as well. Let's understand what the microbes have. We have microbes in terms of bacteria and viruses, like I told you. So bacteria are different types, and then I don't want to go into, and it's a scary slide. So you'll imagine how difficult is virology in terms of people who are delivering all that data to you for all those coronavirus things. So when we talk about viruses, we have DNA viruses, we have RNA viruses, and we have prions and viroids, which are another different segments. But to talk about RNA viruses, coronavirus we know is an RNA virus. I'll go further from here. We have testing. Everyone knows about the PCRs, RT-PCRs, the CT scans, or the chest X-rays, or the amplification steps and so on, and the RT-PCR, the rapid serological testing, which is nothing but the rapid test kits we have, the quick fluid testing kits, which different kinds of fluids are used from the body to do these tests. Moving forward, if I have to talk about, just for a slight shift from here, in cardiology, we look at various genes these days. And what I'm talking about here is something which is a reality, is not a research, which it was about 10 years ago. And we deploy such kind of testing in high-risk patients these days, which is mainly cardiomyopathies or arrhythmic disorders like the tachycardias. And I'm sure everyone knows that every child is born with a hole in the heart, which is closed, upon delivery of the child. But then some have, atrophies or, defects, which are maybe genetic during the embryonic development. And we look at those, and, we can find out, specific disorders which are familially listed here. I'll not go into detail of each one of them. Allow me to move forward. And when you talk about the cancer types, we hear about words like lymphomas, leukemias, sarcomas, carcinomas, myelomas, and mixed tumors, right? And they exist in different parts of the body and can spread from one side to the other. So when it's a primary cancer, it is where we found it, what is the source, where it started from, and we'll go forward to metastatic sites, which are called as the secondary sites for these cancers. So carcinomas are essentially the solid tumors, something which is like a collection of cells and forms a tumor. And to differentiate, I'll not go into many different classifications we may have, but then we'll tell you there are some liquid tumors. Why we call them liquid is because these are the blood cancers. So blood is flowing all across in the systemic circulation. So we call them liquid cancers. So when we are going for testing on these different types of cancers, we deploy screening methodologies like mammography, X-rays, MRIs with various capabilities, and CT scans for sagittal planes, and different kinds of images which are put together. And nowadays we look at the blood markers, then we look at the discretion of an experienced clinician or an oncologist who could not be replaced by the capabilities which are enhancing every day for this imaging and the blood chemistries which we get. And of course, backed up by the DNA testing, if we call cancer as a molecular disease, followed by nutrition, which is getting more important. So even on the molecular end, you can see the wheel there. So we have a lot of things which play together in terms of the best available research evidence or the evidence that is based on the clinical trials and can help our patients as well. We'll see in the forthcoming slides that how we can look at it. This is on the spoke kind of wheel you can see without the circumference here is the various genes and the pathways and how they are connected together. So we have basic sciences, we have clinical reasoning, imaging, diagnostics, genetics, and even the surveillance that is put together to find the right kind of a match or the therapy across the various options of surgery, radiation therapy, maybe immunotherapy, and chemotherapy is what people may have to choose from. When I talk about the pathways in cancer, are even more difficult to understand, which are across, the heterogeneity of cancer types, and the frequencies of these mutations vary across populations. So data which is, population specific needs to be known and has to be deployed. So when we're talking about biopsies, which is the ultimate confirmatory step, I respect those immunohistochemistry, which has been there for almost 100 years and helping us, getting the accurate source from where the origins of cancers have been, and in certain other skin, ailments, and they have been deployed every day. But then there's something that has come up new they call the liquid biopsy. Like I said, the liquid cancers, we even have biopsies which are normally tissues. They're taken out from the specific organ and sent for analysis, where they use various dyes and various other techniques and protocols to help us identify what kind of cells are involved in that cancer. So liquid biopsies are something which we call when the analysis is done for cancers using the blood and not the tumor sample. We'll see in the future slides how it works up. So there are a few terms we use in cancers, which is like the overall survival, progression-free survival, or disease-free survival, and so on. So this is, I would say, a flow, what we use normally to help patients decide and talk about and introducing a word called as a personalized medicine. Like we see that, in many cancers, though the population data is available and the frequencies of the mutations of different cancers, and even in various other diseases, change from population to population. But then we also see that the personalized medicine is that, imagine is a chemotherapy which may work for an X cancer patient may not work for the same cancer in a Y patient. So that is what we want to look and see. And if it is a recurrence or a metastasis, we want to pick it up early. A lot of people want to do risk assessment, diagnosis, prognosis, the kind of life, the overall life, the treatment response, and so on. So we have many questions to answer when a patient comes in and talks to us about the precision oncology parameters. What we have for them is, like, this is a real-time example I've taken from a gallbladder biopsies, where we ran a precision oncology or a precision functional medicine protocol, which runs across thousands of genes and even hundreds and thousands of mutations across the gene types involved in that particular kind of cancer. So we tell them, like, you can see here, like this patient, we had 3 actionable markers, that is 3 medicines that are going to work on the mutations. So in fact, all the drugs are designed, which are essentially proteins, but these proteins are built by the DNA sequences. So I'll talk to you about the central dogma as well. DNA gives out information as mRNA, and mRNA makes proteins. So we have the counter proteins, which we have, in terms of the medicine and pharmacology we have talked about. So in this case, coming back, we have 3 combinations. So there are 3 different drugs, which the patient can have. The percentage in the blue circles, dark ones, would talk about what kind of efficacies they may have in case they are low or middle income group countries, LMICs as we call them, or the cost is prohibitive to deploy these 3 drug combinations. We go for the 2 drug combinations and have the oncologist, the medical oncologist, to select. And there are even monotherapies, which may be, like I said, when we started off, that it's the life cycle of the disease. So maybe they can try the 3 drug combinations first. If it doesn't work and the cancer comes back, you can choose, or there's a toxicity, you can choose between the 1 drug, which is monotherapies, and so on, and various other selections. Even we match the patients with the trials within the country and abroad as well. Now, the other dimensions, after talking about this personalized cancer treatment or the targeted therapy, I would like to get into the cell therapy potentials. So cell therapy potential, if I were to talk about, is across various diseases from the musculoskeletal system, cardiovascular, respiratory, adipose tissues, even the women the women reproductive system, which is uterus, and the cancers which are cervical and so on, or ovarian, and linked with the breast cancers, germline tumors, and we can talk about the kidney disorders. So, but then for that, I have just brought about here is the various classifications of cells that may be important here. When we talk about the blood forming stem cells, they may be important. So we leave it to the stem cells and what the types of stem cells and how they mature inside the body. And the immune system cells, which are monocytes, macrophages, and they further, important ones would be dendritic cells, neutrophils, and so on. And of course, not to forget the T cell and the B cells, because most of the liquid cancers, we look at the T and the B cells, and certain, frontier applications are based on these. When we talk about the gene therapy, there are 2 ways. We actually, let's take it simple, like a layman person, is that we take the genes and we would like to deliver it inside the body. The genes which are modified or restructured, genetically engineered with the potential to cure the disease, which can be done either directly, is the delivery that can be given through the injectables, but it's like a therapeutic gene we have to talk about. Now we call it as transgene because we have transcribed, we have changed this transcription factors here, which is in the transcription area of the DNA or RNA, so to say. And then, delivery mechanism is like, we can always get it onto, a carrier called as a plasmid or a virus and inject it in. Its principle of, the current mRNA vaccines would be slightly similar, but totally different when it comes to manufacture and deliveries. But then that's the concept of the gene therapy, for which we employ a protocol called as the cloning. Cloning means, imagine there is a necklace. There's a lady with the beads, and beads you can see in terms of the DNA, small fragments, which are, of course, stitched together. They're not separate ones, but they're linked together into the green area of the ring I have here. And the magenta looking region, which is like maybe a diamond in the necklace, would be the gene of interest, which I have artificially transfected, which I have introduced into a natural DNA, and I load it onto the viral DNA and let it go. So the DNA on what we load, as you can see now, our DNA, which is the modified one, which is in the magenta color, we load it onto the plasmid DNA, and we have a double-stranded molecules, and which is essentially DNA, and we can use them readily as gene therapy products. This is a similar presentation, and I would like to skip this slide and look at the gene therapy essentials. Essentials would be, we need a plasmid DNA. We can use the viral vectors, as I talked about. Now, this is a word I was keeping it towards the end. So viral vectors is what we have been reading severally these days. Then we have the bacterial vectors. We have human gene editing technology, which you read every day in newspapers maybe, or online journals, which is called the Casper gene editing tools. which are nothing but enzymes which can help us cut the necklace in a specific place I need to go. Going forward, you'll be surprised that there are so many gene therapy products. I could not get everyone here, but I'm missing out only a few which can be counted on the fingers of the hand. But most of them which are approved by the FDA exist. These are the cord blood cells which are looked at, trying to cure the disorders which are existing out of the donor hematopoietic progenitor cells transplantation patients who may have a secondary disease, I would say, post the transplants they have. Then there are multiple myelomas, which is essentially strikes the bones of the ribs to start with, and can be a very difficult proposition for a person who is into advanced stages. And we have now DLBCL, you can see. I'm just going random on these, not one by one, but then that is diffuse large B cell lymphomas. So if you remember, I was talking about the T cells and the B cells and the liquid cancers or the blood cancers. So we have the B cell lymphomas. So people will always ask me, see, lymphomas are nothing essentially but liquid, but then they can form a mass in the lymph nodes or something like that. They have swellings. Patients may, have a different symptoms, like it's not the blood circulating. So important thing to understand is there are certain cancers called as the lymphoblastic leukemia, which means a leukemia which is having the features of a lymphoma. So two quick things to remember was I was taught that the blood cancers would be like the milk, and over a period of time, they trying to get together and form something called as lymphoma, which is like a butter, right? So on the right, I have one under the CAR T cell therapy under the FDA logo, which stands tall today. And the CAR T cell therapies are the new ones which have come in for last, I think, 2 or 3 years now. And we saw less movement in this area for because of the COVID. And I'm sure it's picking up now again. So in a CAR T cell, so the T cell therapies, if we have to talk about, so we can, in fact, on the left, you can see the site A. This is designed from a slide which we are trying to run at a premier hospital in India. So we are trying to have the cells drawn out from a patient, from the peripheral blood, and we are trying to, grow the cells and, store them in a specific, for 14 days, we grow them. And introduce a viral component, which is the gene therapy component, and we check on the flow cytometry is how many number of cells we have, and transport it to the other site B, where an infusion and monitoring can be done. This, by chance, is one of the costliest drugs for a single dose therapy, can go up to $500,000. Trust me for that number. So we are trying to establish it in India. And we're happy to say, while we are talking to you, we have gone down as low as 30 lakhs of rupees. And I'm sure it'll go further 5 steps down. Something which we don't talk about these days is I would love to have those BMT, colleagues of mine who have been doing this kind of a job for years together, almost a decade, I would say. So bone marrow transplants are usually done for cancer patients, leukemia patients, blood cancer patients, especially the children. And you'll see the conditions which are different kinds of cancers we're talking about. So it's like usually the childhood leukemias. So there are a lot of BMT centers you have, but they work with the stem cells. They, have, the antibodies on the stem cells loaded, and then we reduce the volumes so that it becomes injectable. And it's a very promising therapy, which has been happening worldwide for almost, a decade now. Few centers, I would say, are good in Mumbai, who have been working with me on few patients to be supported. So allow me to say, we have to understand what a cancer is. In all my research and 20 years I have given, and looking at patients and so on in the clinics and so on, I have felt that there could be defined by 3 words, which is the cancers can proliferate, pervade, and regenerate, which means they can just have an activity within a cell, right? And an organ. And then they pervade means they try to cross the borders. Like it's the wars, which are civil wars, and now the wars over a period of time may become, the border wars. And then when the cell crosses onto the other side, it may create its own vessels, the blood vessels, which is step 2. And in number 3, you can see the epithelial cells turn into the mesenchymal cells, which essentially lose its own bondage, which is they're held tightly together to the to the walls, but then they lose their rigidity and they start flowing into the blood. And in the step 4, you can see they can go and start creating or regenerating, if I have to say, and cause metastasis or the spread of cancer on the another side. But usually it happens to the blood, and blood goes parallel with the lymphatic system. So it's through the lymph nodes. So which is why many times we actually take out the lymph nodes for patients who, when we perform the primary treatment as the surgery. The below depiction is like various steps we call about, is the cancer in situ, which is a step 1 you can see here. And when it goes invasive, it is pervasion, and metastasis is regeneration. Now, in the moving from this particular region of cancers and detections and so on, allow me to go towards the therapy. Towards the left, you can see that necklace. So imagine if it is a DNA sequence and a chain. We normally are, having drugs which are, which are targeted therapies. So we look at the DNA makeup of the tumors, and we give them drugs, which is precision oncology or called as the targeted therapy. So in future, we'll have drugs which will have multiple regions on the DNA. So chemotherapies, and they or other drugs, which is like immunotherapy. So precision medicine or precision oncology or molecular oncology or integrative oncology, these are the same words for all the things we do together in an integrated form. And these cancers, we'll talk about data, which is immunotherapy. It'll have the markers which I've talked about. It talks about the real-time evidence of the clinical trials which are happening, because it's so evolving so fast that we need to have keep a tap on that. Following the the targeted therapy we spoke about in the last slide, allow me to move again onto yet another paradigms shift in the treatment, and that follows is biopharmaceuticals. So on the left, this is called the central dogma. We have the DNA, makes RNA, and then proteins. But what we're trying to do is, if you can see on the right-hand side, the red color, the antisense drug. This is nothing but a sequence which is anti to the usual sequence on the second strand of the DNA. I, in fact, want to change that. So in the lab, I can do that. And with the protocols, we, add an antisense to the mRNA so that it joins, or, the translation doesn't happen. So it doesn't form the proteins. So that is what we are trying to achieve here. So this is what is called as the biopharmaceuticals. And a lot of people ask me when I tell them, you're a doctor who works with DNA and cancer patients and so on. I said, yes. So, and then they ask me, oh, do you know that there's a 16 crore rupees injection given to someone? So I said, yes. So, so this is what biopharmaceuticals are, which are nothing but, I'll go back for a second. The antisense you see here are synthesized using chemicals. Earlier, they were being used for research, but now the biopharma companies, there are many in India as well. So they're looking at, synthesizing or producing or manufacturing the synthetic DNA with something called as the amidites and few other chemicals. So we set up something like this in 2 places in India already. My team is working on those. So these are the drugs which are already approved as oligonucleotide drugs, which are long, molecules, or called as larger molecules, and can be biosimilars, but then the real would be oligonucleotide therapies. Oligo means it's multiple units of DNA sequence is oligo, and nucleotide is nuclear, each unit of that, ATGC. Frontier applications in this would be, now we're trying to establish that, if we could have a COVID treatment with this, right? So we have an international group which is working now. So I've taken the data published recently. And uh, so I see Dr. Shetty raising hands, but then we'll come back to you, sir. And so going forward, we have on the right, these are the molecules. You can see the indications. These are the indications all the way from Huntington's to DMDs, or even dry eye syndrome, atrophies, beta thalassemia, and so on. They all have a potential with the synthetic oligonucleotide biopharmaceuticals. There are two difficult things, out of which one I felt in life was to be, to be thorough in one's learning and be very exhaustive in investigations, which also is depicted in the slide here. We may have clinicians across specialties. They may have about 2,500 different articles to reach every year. So imagine how much and how much time would you have to read through all of them in a day. So 2,500 divided by 365, let's say 300 working days, and 26,000 tests, which are genetic tests, which are available across more than 500 conditions. But they are fever guidelines. Most of them are working on the basis of the best available evidence, called as the evidence-based medicines, also used in trials. We also understand that blockchain, which you think about and read about, is the technology being used in the cryptocurrencies. In fact, it started as a mathematical tool for the biotechnology, applications. Pitfalls would continue because we all have this data, and we talk about the artificial intelligence, which got a subset called as the machine learning, which could be like your dictionaries, right? So, or a deep learning, which is even further down. So when you type something on your cell phones, over a period of time, the names of the proper nouns or the names of your own friends or the common words or even the names of medicines, my phone, I could, I was amazed that it can pick up medicine names which are very difficult, because it remembers and creates a personalized tool as a dictionary for you. So this is what we understand from deep learning, but then these are the challenges. Algorithms are not common. So while the colors, I would say, are changing for humans, and we have the integrative medicine, which is something like an upside down way to treat patients. I think the paradigms would be how we diagnose and treat them. So where do we stand? So allow me to just give out some questions which could help you decide as how we are going to treat. The awareness, diagnosis, treatment, and diets and reviews is what's going to be the future of medicine and how we'll treat patients. Now, from here, we'll enter into certain dynamics, and I'm happy that I'll cover one or two slides which have been from the last year, January 2021, when I was rather January or February, where I was standing on the same stage and talking about vaccines. So allow me, and let's understand. There are a lot of good and bad news that's coming in from nature or the nurturing attitude we may have. We say that maybe the killing of the mind is something, the academy of ideas. This is a good one I picked up from there. We have a lot of things to look at. We have Dr. Google, we have Dr. WhatsApp, and then we have a lot of data points staring back at us. And these are all situations which are creating mass psychosis today. And finally, we have no clue and get up onto the right bottom corner at, all right, I support something which is current thing going on. But then we don't look at what are the kinds of hats, what are the kind of work we are doing, and how many people are putting it together. And the free-floating anxiety is just causing aggression and frustration. Because in the post-COVID area, I had to talk about this. We'll be treating many other disorders apart from only the COVID conditions or the toxicities. We have a much more harder and a difficult preposition in front of the clinicians, and we have to tighten up, and maybe it will go on for a very long time. We'll be feeding out of the data which is being there. So if you see from the past and the future, I think the fee would be given away only after the outcomes will be realized. Many of those doctors were, in fact, staring back at us and denying that maybe the molecular diagnostics would and molecular interventions may not be the future. If I talk about 15 years back, but then now in a lab, we're trying to do more of algorithms because it's not physically possible to have a roadmap for a disease with so many mutations, thousands and millions of data points being collected every day. So more of the things would go more virtual, personalized, crowdsourced, AI enhanced, right? And we have to be living up to that. Very important slide, and I'm happy standing here to say that in the issue 43 of the series 1, right, almost halfway down in the last year, January, we talked about these vaccines. And I've just colored that here is that, we were talking about the clutters which may be, or the toxicities which we may have in terms of the viral vectors which we use. So it is in fact something which is, it is not relatively deployable, I must say. When we talk about molecular medicine, we talk about molecular diagnostics, nothing is absolute. But then we were talking about that it can leak into the bloodstream and infect the liver. But then now we have data which is there. I'm happy to say we were the first ones to predict from here in India. Now we have certain things. When the vaccines take the route of the liver and enter the systemic circulation, you can see something on the right hand side. So when we say transcription in the central dogma, so transcription means DNA gives the genetic code to RNA. RNA carries this forward in the form of messenger RNA and gives it to the ribosomes to make the proteins. But then if this goes reverse, or it's retrosposition, if we call it, or it is reverse transcribed, RNA never became a DNA, but in this case, it may give rise to something, enzymes, which can promote that within the cell, called as the line 1. Line 1 are nothing but reverse transcriptases, and we, shall I say, need to brace for metabolic disorders, cancers. So this is a study which has come up recently, and it's been talked about. And there is some data which has been released 2 days ago by the UK government, which is not looking too good. And it talks about that is 3.2x times more that rate, which they have just revised the data and gone by. But anyways, we move forward. We'll have more changes the way we look at controlling our data. This is something filed up by the WHO recently, and it's a pandemic instrument wherein the WHO will hold more powers in future pandemics. Though they had one in 2005 as a treaty between countries, but I think the government going forward in future pandemics, this is still being debated. They meet on the 22nd of March this year, to be precise, but then I'm sure they'll have more changes, and we have to restructure ourselves in terms of data sharing and the tools to be deployed in our everyday clinical episodes. Unfortunately, there were mixed stories we got from Sweden, which looked at the evidence and they felt that the knowledge was not sufficient, and they've turned down the vaccine, whereas for the kids between 5 and 11, whereas when we go about the Moderna, which has been in controversy for a very long time, has been approved. But then this is a very important slide, and you'll not like me to say that all the things we are looking at, the logos on the right hand side, are the few I have picked up around about 768 applications which have been submitted on the data.gov.in. This is Indian data I've picked up from the Indian website, which is run and controlled by National Health Authority. We will have under the Ayushman Bharat digital mission going forward, companies like Paytm, Reliance Digital, this is data there, right? I stand by each word I am trying to share with you here. Under the digital mission, there's a website called as the Sandbox. So if you go there, you'll find all these, imagine Paytm would be collecting healthcare data. There's a silence, yes, but then it is. And Reliance Digital, Practo, we all know about. Apollo Hospitals is a leading player already. SRL, and there are many more. There are 768 applications which are currently on hold, and about 36 have been given a pass. So this will become the backbone of how we'll be treating, and you can see the depiction and the different steps which will take. So all the data, maybe the health cards would be delivered, and we have to be ready for this. We cannot really go by, but then it may have different, we are talking about CRISPRs in the ethics. We're talking about social security numbers. We're talking about the genetically modified babies. We have meat products which are more vegetarian, which are sold in Singapore now, and we may talk about mutant soldiers. I'm sure people might have read some, seen some documentaries lately. So this is the time you feel that it may be closer, but no, it is closer than what we think today, and it's already there. So with those things, I would leave you with the picks you may have for the frontier applications and how good they may be. But then I would leave it with the first three words of the Hippocratic oath we all take, which is the primum non nocere. First, do no harm, and then proceed further and analyze, because discretion is going to play a very important role. And like we have the founder of the Mayo Clinic say, the glory of medicine is that it is constantly moving forward, that there is always more to learn. The ills we may have talked about today, or something which is close to my heart, or something which we may not agree with today. So the ills of today do not cloud the horizons of tomorrow, but act as a spur to greater benefit. So allow me to end my presentation here with a thanks to the audience, and to help me deliver this important lecture. Thank you very much.
So thanks a lot, Dr. Puneet. I think it was as interesting, and I think what it also gives us a message is that this field is so new and so upcoming. It's really important for us to keep abreast of the changes. I see that we have questions, so let me first begin with Dr. Gajen, who has a question.
Sure.
First of all, I congratulate Dr. Puneet for such a wonderful talk. The topic was very, very difficult, but you made it very easy for all of us. And not only that, you covered all the things in great detail. And right from the primary cell structure onward, you have come up to the last. So this is a wonderful talk. So my heartiest congratulations on that.
Thank you very much.
Now I got a remarks and a question to you.
Sure.
My remarks is about your last slide regarding Ayushman Bharat digital mission. Let me tell you, Dr. Saab, the way the systems are working in the government, this will never occur in India. Even government do not have a complete data of its employees. Leave aside the total population, which runs into 1.35 billion. And the government number of government employees is just 50 lakhs. Complete data of government employees is even not available, central government employees, not talking of state government. So in such a scenario, it is a huge task, and I have very much, I have my own apprehension that it will never ever be, completed. So this is one. This is my remark. Anyway, let us be hopeful, and with the new technology, maybe the things will improve over the period of time. Now, coming to my question is regarding this treatment of especially blood cancers, lymphoblastic leukemia, the gene therapy or bone marrow transplant, which is considered to be the best, and if there is any role of stem cell therapy.
Right.
I mean, you have not touched upon that stem cell therapy.
Right. So essentially, let me say that, allow me to put a statement that the bone marrow transplants, in fact, are transplants done using the stem cells of the patient or a donor. But donor in this case is very limited as a efficacy in past whatever work has been done. So when we are talking about which one is better, the bone marrow transplants or it is the gene therapy. So currently, I would say the decision has, or normally in many therapeutics which are novel in terms of cancer treatments, they are exorbitant in cost. So cost is something which is a factor that, rides over the benefits or the harms of the therapy, which comes secondary or tertiary. The primordial importance is or something that sits as the bastion is the healthcare system. We don't even we have come across patients who may have, a need of certain, novel therapies, but then they're already into the mainstream of the tertiary care in India. But certain government sectors, excuse me for saying that, but then they would not recognize those immunotherapies because they end up as above the assignable or approved limits for certain employees, even in places where the hierarchical, healthcare, approvals or facilities are based, like the officer levels or others. But even in places where it is not existing, like public sectors, still we find a problem. So I would say, in terms of the money or the expenditure, that is the first deterrent. And usually people go for a bone marrow transplants, which is easier and can be done. And it's, I would not say cheaper. It is relatively, affordable.
Established.
Yeah.
And
Affordable, I would
more,
say.
it is
And, yeah.
already
And then,
established.
yeah. And then established. And then we come to the second one, very rightly said. And the third one would be still the gene therapies are very costly. We are still gathering all the momentum and the data and the patients. In fact, we were talking about in the leukemias. So in leukemias, we have a drug called as, ocitabine, which is, in fact, a hair removal, cream which people use. But the same drug is now being used as DFMO. It's the abbreviated form, dimethylfluoroornithine. We're not able to get that. It may be, a revolutionary thing for patients with DB, with the leukemias. And but then we are not able to get it. So we are trying to go back force every day, push the system so that we can get those therapies which are working here, irrespective of the cost. And of course, the Make in India and other things, I hope that works too, besides the data we collect, which is, I beg to differ that it's maybe collecting data. There might be apps on my cell phone or maybe on Zoom or anything who is collecting all the data, what we are speaking, where we are, what is the bank account money I have, how many transactions I have done, how many, what is my, so it is I think the companies who are, the private companies who have resources are being deployed in the PPP mode to collect that. So I hope it answers both of your questions.
Thank you. Thank you
The
very much.
second one was only, I believe it will be done. There's no choice. Right, sir. Thank you very much.
Dr. Ashish.
All right, thank you. So I think that's great insights. I had also noted that Dr. Shetty had raised his hand. Dr. Shetty, would you like to ask any questions? Okay, I think he has lowered his hand. So I'm opening up the floor now to any other questions which might be there from our audience.
Sure. Maybe everything was alien, or it went, I did it the bad way, maybe.
No, I think people are taking time to absorb.
Nothing is understood.
Topic is in fact very, very difficult, but you really made it very simple. And I think everybody has understood everything. So there may not be questions.
Right.
Dr. Puneet, I had a question since I see no more questions. Now, I think you talked about the biotherapeutics. And when we talk about, you said that there are certain drugs and molecules which cost several crores. Now, I know that when we think of this, and in the past, there have been organizations like Novartis and others who have been putting up something which was called as a lottery scheme where people can apply and perhaps gain the benefit of not putting up the entire cost, but going through the lottery system. Considering the fact that when you think from the cost perspective, it is still prohibitive, and not only in the Western countries, but also in India, it's significant. Do you see any ways by which people are able to kind of take this up in a much more reasonable manner? I know that as of now, insurances don't cover it, and even there is no direct kind of approach apart from a lottery system by which people can enroll. So what's the way out if we kind of think for people who are based out in India, keeping the cost in mind, but is there something which the government can be doing? Is there something which you see that perhaps institutes like Tata or a couple of institutes are doing, because there is a big population. Presently, these people would be going across to the Manipals, to the AIMS, but as of now, the treatment is not very clearly available.
Yeah, a very valid question, Dr. Jain. And I would start with saying that most of our premier cancer centers, or like say lead centers, I would not name them, but then most of them, you name them in Delhi, and starting from Delhi, or you talk about certain tertiary centers for treatments of the maladies. I'm sure everyone is getting what I'm talking about. Our lead centers are just about validating centers. They're not treatment centers. A test which may be a genetic test and may help a patient to select a chemotherapy that works, he can gain time and control the disease and live longer, if not better, without a toxicity, at least the disease-free survival or overall survival. That benefit comes to them at 20,000 to 30,000 rupees. Beyond a project which is given off or given away, funded by the government of India, and after those number of patients are tested, the entire thing dies. It's unfortunate. It dies. And nobody is offered that test after that, in spite of large machines with high throughputs we may have. I think each center would have 5 times more the number of samples throughput capability in each center that can take care of the whole country. But then we are not deploying it. Maybe like the RT-PCRs. You won't believe me that there might be about easily more than 50,000 RT-PCRs in our government setups. So can we talk about 50,000 different labs across the country to do COVID testing? But it never came up. We had only a couple of hundreds maybe, but not thousands, right? Likewise, we may have, when we talk about the therapies which are coming in, the therapies are also, people come together, centers come together, validate it, collaborate, publish, and that's about it. Because if in a government, they start giving it at one end, it becomes a precedence. Like something happens in a high court in Chennai or Madras would be a precedence of all the high courts across our country. So I think even if they want to, they would not like to set a precedence. So which is where the government has to come forward and understand and make a committee and see that what are the things which are affordable. And as you rightly picked up, there might be the companies, the pharma companies have to come forward and look at exploring their trials across the country, not only with those centers, but then if there are nodal centers which are already established for that kind of hierarchical blessings we might have to take from them. But I think the other centers at district level should be taken up. And there are schemes which are currently running which do not reach the customers or the of the pharma or the patients who actually need them. So there are schemes which are held in between. I will not name them. We get some it's like a 2+1 or 1+2 also, but it is not given away by our private hospitals to the patients because their system does not allow it. So maybe a uniform strategy as far as trials is concerned, and a uniform, I would say, marketing efforts are put together and they work with the committee. I think it's benefiting both of them. So that should be the way to go.
Thanks. I think there is definitely an opportunity for collaboration. It needs to come all across. So it's a public-private collaboration with the government and the global bodies coming in. And I think if we are able to kind of establish that system forward, it would enable a lot of people who are especially affected, or the children or the families are having issues. So I think they would benefit a lot. Thanks, Dr. Puneet.
I would like to just add, Dr. Jain, I missed out on one point you had asked me. Like, crores of rupees, one injections which are given. Trust me, if we make those oligonucleotide synthetic DNA so-called products in India, that whole product can be given at 2 lakhs of rupees.
Wow.
And I stand by that word. I am making.
Wow.
Right.
I think
Just
that's
making for-
quite big and significant, and I think that will be a revolution if that can be done.
So we are
Really,
working
I think that's
forward.
a great step forward.
Dr. Jain,
I would,
Dr. Tyagarajan has raised.
yeah. So, Dr. Tyagarajan, would you like to
Yeah.
share your feedback?
Thank you, Dr. Jain. Congratulations, Dr. Puneet Chandna. Wonderful. You have prepared very well. A lot of homework has been done. Just like, don't mistake me, just like Mr. Putin of Russia, who prepared and smashing Ukraine, you have covered everything very beautifully. Beautifully, everything is so much interesting. Every word of yours is so much interesting, and we are really, it's a learning path. And thank you, sir. Gajendra Kumar, sir, you are reaching towards century. And it's a great honor, especially for AUHD under your leadership. Congratulations, Dr. Puneet Chandna. You have covered everything, and many of the things we were not knowing, and really it is an interesting. Only thing is, like Dr. Gajendra Kumar has said, ours is a 1.3 billion people. Make a data is very difficult, because I tell you one thing. I had a just now, no, this one is 2 GB. It is already crossed, so they have cut it. See, internet there, it is already gone.
Maybe
because,
they don't need
2
your
GB it
pictures
is.
more. They need your data more, which they already have.
No, 2 GB per day. It is just cut. So this especially private partnership, no, for people, especially in villages and all, they find it very difficult, because if it is covered under insurance and if it is the big people, it's maybe helpful. But India is a very big country, needs a lot of calculation, and health, especially health and shelter, we people ask for, it is they say subsidized rate. Okay, anyhow, thank you. You have covered everything. Wonderful speech. Beautiful.
Thank you very much, sir. It's a pleasure.
Thanks, Dr. Tyagarajan. And I think I'll also check for any other feedback, Dr. Auditor or Dr. Parekh, in case you have any other suggestions, comments, feedback to share.
I could see one Dr. VP Singh, I guess. Yeah, sorry. Go ahead, sir.
Good evening, sir.
Good evening, sir. How are you?
Sir, it was unusual subject for all of us, but you presented like anything. It was in very simple manner.
Yes, sir.
Because to understand such kind of topic, it is quite difficult for each and everyone. Because usually we are not used to such kind of subject. And in industry, usually we are not talking such kind of subject at all. So it was wonderful. And as usual, you are so fluent and dynamic speaker. So we enjoyed fully. Thank you so much, sir.
Thank you. It's a pleasure.
So very good presentation. Thank you very much.
Thank you, Dr. Sanjay. It's a pleasure to be with you.
So I think we have now come almost to the end of the session today. I really want to thank Dr. Puneet for coming over today and presenting this in a lucid manner. The hallmark of a great teacher is simplicity. And I think Dr. Puneet has actually proved this again today, making a subject interesting, making it really captivating, keeping the audience spellbound. That has been some of the hallmarks of Dr. Puneet, which I've also seen in the past. I continue to see the same, and thanks for actually ensuring and keeping us abreast of all of the modern advances. We would definitely be looking forward to again catch up with Dr. Puneet sometime in the future. But at the same time, I would now have all of you a wonderful evening. Wish you all the best, and have a great weekend. Thank you so much.
Thank you very much.
Thank you all.
Thank you.
Thanks for coming here.